result than a non-idiopathic. Thank you.
So, thank you. After removal of the cast and the KOIs and everything, how you maintain how you any braces and how you deal the patient?
We put the braces in a well-molded ankle foot orthosis.
Ankle foot orthosis you use only for 3 to 4 years and 5 years.
Generally give for the 1 to 1.5 year. If it is getting better within that, we have to discard it. Okay. After 1.5 year, discard brace.
Thank you, Hitesh. Now I call all the speakers. Please come.
So do we have more questions?
For questions
And subtalar fusion, do you mean rice green? If you are doing in a, say, 5-6-year-old.
Yes. If it is that generally less than 5 years doesn't require subtalar fusion, because in our experience we did up to 6 years, it works very well. But between 6 years to 9 years, we have to do about the rice green procedure. Sometimes it is like a very, very severe navicular is up that we can't do about the lengthening of that, the medial column, we have to excise the navicular.
So, Dr. Ritesh Pandey.
Sir, what your experience regarding 3 incision procedures?
Yeah, we used to do about
because we have used 2 or 3 cases with this.
Yeah, but what I said that ultimately you address the dorsal structure, lateral structure, and posterior structure.
Yeah.
So there are the 3 incision. So if you do with the 2 incision, it will be okay. If you do with the 3 incision, it is also.
Because your anterior incision is something long like and something like anterior Cincinnati type incision.
Yeah, but it works well. Okay. I can understand. We used to do about 3 incision also before that.
Thank you, sir.
See, once you try this dorsal approach, you will see that it gives wonderful exposure. Once you do it, then you will not resort to 3 incision technique.
Thank you, sir.
The percutaneous technique. With the percutaneous technique, how much time would you need? I mean, how many times or percentage-wise you'll need the soft tissue release along with that?
If child presents very early, and it's idiopathic, it will works well with the percutaneous technique. If child is present beyond 6 months and non-idiopathic, most probably they will require about soft tissue.
Do you think oblique talus, the modified Dobbs works?
Yes.
Oh.
Yes.
So probably his series is, oblique talus.
Yes. Yes.
One of the problems with vertical talus is it's a mixed bag of cases, and if you have a majority of oblique talus, you'll have excellent results. But if you have mostly arthrogrypotic, really bad vertical talus, whatever you do, they do badly. So you have this kind of range of presentations which some are so, I mean, I know 1 or 2 cases where it's run in the family with arthrogryposis, and whatever you do to them, they do not correct. I mean, not fully. I mean, they'll correct, but exactly. Yeah. So they can be really challenging.
So oblique talus, you would follow exactly the same protocol like you would do for vertical talus. How would you, exactly differentiate between an oblique talus and a severe flat foot?
Okay, that's a very good question, and I must not say, but Hitesh, me and Vincent Mosca are doing one study following X-rays, and we are trying to define this criteria. At this stage, we don't have any clear-cut criteria to differentiate this. Let's hope that we may get some results from our study, and in a year or so, we will be able to tell well what has happened.
The oblique talus is in between, but there is no fixed criteria to define all 3. For CVT is very simple to do. It's very, very simple to define because it's not getting reduced, it's a vertical talus. But between the oblique and the flexible flat foot is very, very difficult on that. Yes. Yeah, but fortunately for the orthopedic surgeon or pediatric orthopedic surgeon, if deformity is getting the fix, then he is going to intervene. So it is like that. So even the criteria is not defined, they know about the treatment.
Ritesh, please.
Thank you, sir. I thank John, sir, Dr. Jaswinder, and the whole organizing team for making me a part of this event. And after uh, having seen the beautiful results of Dr. Hitesh Sasar's cases, I will be presenting two cases of CVT where the results of surgical treatment were satisfactory, but they were not optimal. And I think all these discussions apply to my cases, and it will generate a lot of further discussions. So this was first case, a 5-year-old girl, known case of spina bifida with bilateral calcaneovalgus foot deformity. And this is how she was walking. The deformity on the left side was severe and it was quite stiff, whereas on the right side it was flexible and completely reducible on manipulations. So these were the AP images, and although the deformity is appearing to be more severe on the right side, as I told, the right side was flexible and it was reducible, whereas the left side was more stiffer. And these are the dorsiflexion and plantar flexion views of the left foot, which was a stiff foot. And here, as we can appreciate, the talonavicular joint is partially reducible, and there is 10 degrees of dorsiflexion in the dorsiflexion lateral image. Whereas on the right side, the deformity is completely reducible, and good amount of dorsiflexion is also possible. So the following diagnosis was made for this case. On the left side, we have a congenital vertical talus, which is partially reducible, whereas on the right side, we have an oblique talus. And this treatment algorithm was followed for this case, which was published in Journal of Posna in February 2022. And it says that even in neglected cases, all the cases should receive a trial of serial stretching casts, and if the deformity is reducible or even partially reducible, then one can try Dobbs method of minimally invasive treatment. Whereas if it is a stiff foot or a recurrent case where the deformity is not reducible, then more extensive dorsolateral releases with or without bony procedures are needed. So the same treatment was done for this case. She received serial reverse Ponseti casts followed by Dobbs method of treatment consisting of open reduction of talonavicular joint and a TA tenotomy. And these are the intraoperative images. It is showing good reduction on both the images, both AP and lateral views. And these are the images in cast. The same treatment was used for both the sides, both left and right foot. Even though for the oblique talus, we used the Dobbs method in this case. And post-operatively, K-wires were removed at 6 weeks, cast was removed at 12 weeks, and an AFO was continued thereafter. And these are the results. This is how she was walking at the end of 6 months. There is significant improvement on the left side, which was more stiff. But on the right side, which was flexible, it is the deformity has again recurred. And even the radiographs at 6 months are showing signs of recurrence here. This is for the left foot. And the status of right foot, which was oblique talus, the status was same as it was in preoperative period. This is another case. Again, a 5-year-old boy with left calcaneovalgus deformity. Here it was idiopathic because I could not find any underlying cause in this case. There was a history of dorsolateral release a couple of years back, and the foot was quite stiff. And these are the images of the deformity. You can see the scar line of previous surgeries. These are the radiographic angle showing deranged alignment and a vertical talus. So here we made a diagnosis of idiopathic congenital vertical talus, which is recurrent and it is a stiff deformity. And again, the same algorithm was followed. We gave a trial of serial reverse Ponseti cast, but that didn't give any improvement. And an extensive dorsolateral release was done. Open reduction of talonavicular joint was done. And as Hitesh sir told, I prefer to do a tibialis anterior transfer to the talar neck in this case, followed by a TA lengthening. And these are the images. Again, both lateral and AP views is showing good reduction and good alignment. And these are the intraoperative images showing good deformity correction. These are the images at 3 months post-op. But again, at 6 months, the radiology is showing the signs of recurrence. And as per the literature, there are various papers with different percentage of recurrences quoted. And few papers have quoted a recurrence rate as high as 67% for Dobbs method and up to 30% for extensive releases. And it varies, and it is more for older age and in teratologic CVTs. So now the cases are open for discussion, and like what went wrong and what else could have been done in these cases. So these were the various options which were discussed by Hitesh sir also in his PPT. So what could have been done further to improve the results?
The first case, which is having spina bifida, I think we need to check about the muscle imbalance, because there is a I think the first case, which is very severe on the left side and right side, was supple. The left tibialis anterior is very, very tight. And what has been addressed, because tibialis anterior, if you do the lengthening also, that you may do about weakening, because the plantar flexion is not working and dorsiflexion is high. That's why it's going in a lot of calcaneus type of compared to left side, left was stiff and right was not stiff. The right has not been addressed. That's why right looks little awkward.
The right probably needs something like a, how old is the child?
5 years old, sir.
Yeah, something like a Grice green or something like that, because it's not gonna, it's not gonna work with soft tissue surgery. Okay. And for the left, I guess you needed more, a better release and a better reduction of the angle of the talus.
So I mean, even if
How long did you keep the KVAS?
K-wires for 6 weeks, sir, and plaster for 3 months. So even if intraoperatively one is getting good reduction, good alignment, then should they proceed for extraarticular arthrodesis in those cases, in these scenarios?
Not in during the first time, but if we say it about during the first time, if you see the underlying neurological imbalance, you can balance it, because otherwise it will recur in case of the neurological problem. That's why the non-idiopathic are much more difficult. Sometimes it's unpredictable. If you do the surgery at 2.5, 3 years, you cannot find out the muscle imbalance. Generally, it's not because surgeon's fault, because we cannot detect it. It's retrospectively we can detect. It's not the fault of the surgeon. It's that generally because of the etiology we can't find out.
I think the left side is just extreme calcaneovalgus rather than a true vertical talus. Yeah. It's like because of the extreme calcaneovalgus, the talus is kind of looking down. So I think you need to correct the bony relationship of the thing, and something like an extra, at this age, probably an extra articular arthrodesis. Later on, you may have to do a complete further arthrodesis if necessary once the child is
The
older.
role of the medial column shortenings in these cases, like
Yeah, it is described also the medial column shortening. That's why we discussed that is a difference between lateral column and medial column. Medial column is longer, so sometimes you need to do about the osteotomy and do about the shortening osteotomy. It's also described.
Something like wedge tarsectomy on the medial side.
Medial. Reverse of the clubfoot, well, we do about the cuboid, the enucleation or cuboid osteotomy or mid-tarsal osteotomy or Lichfield osteotomy. Same thing on the medial side. We can do about the no, cuneiform. Medial is on cuneiform mostly on that. If it is severe, then you have to take it out, excise it.
How does excising navicular behave, sir?
It doesn't behave very well because it will compromise the two joints. Actually, it will compromise the proximal and distal. So the movement would not be happening. So this would not be considered as a first option. This is the last option.
So it will take care of the length part, but the joint between the talus and the cuneiform is not really a good joint.
It can do, actually, it's the people try to do about the osteotomy or the two level to preserve the joint. But again, it can lead to its own complication. Like you can do about the medial cuneiform osteotomy and the shortening osteotomy of the navicular. But again, they will have their own problems.
So in practice, sir, what will be your recommendation? Means up to what age one can go for these joint preserving procedures? And
As far as possible, we should, because if you, in case of the spina bifida, if you fuse the joint, it will lead to the other problem like a trophic ulcer. You'll have if the person has got sensation problem. So, as far as my concern, I treat this spina bifida not very aggressively do with the surgery. I will do the brace them, and check about that whether the established muscle imbalance is there. Then only I will do intervention.
You probably have to delay your surgery as much as you can rather than do something in a rush, because these spina bifidas behave very well. And the muscle imbalance is something which you need to look at, because the weaknesses, also whether the spina bifida has been adequately addressed. So some of them may have tethering and the neurology may actually get worse with time. So need to.
Now, and we'll close this session. May I ask Dr. Ritesh Pandey to felicitate our chairperson, Dr. Vinod. Thank you, sir. Sudan, sir. Dr. Madhusudan, sir. Thank you, sir. Dr. Bhuvan, sir, please. Dr. Ekram, sir, please.
Flat Foot and Tarsal Coalition, may I invite our chairperson, Dr. D.K. Sinha sir, Dr. S.S. Jha sir, Dr. Juvendu sir, and Dr. Vikas sir. Please come to the stage, please.
CTEV, probably one of the most common pathologies that we see in the pediatric foot. Now we will go on to flat foot, which is not a pathology, but there are a lot of myths and misconceptions and fears in the minds of the parents, and it is our job to dispel those fears based on scientific evidence. As we go along in this session, we will realize that most of us, many times we, to allay the anxiety of the parents, we often do irrational things like, every child with flat foot, there is a tendency to prescribe insoles, and then I'm sure that, as the talks go along, we will see what is really the scientific evidence, which children should be prescribed, which children should not be prescribed, what is the evidence in favor and all this. So my job today basically in the first talk is to talk about the pathoanatomy, the types and differential diagnosis. And this is what I'm going to talk about. What is flat foot exactly? What are the types of flat feet in children and what are the differential diagnosis, right? So what is flat foot? It is loss of height of medial longitudinal arch of the foot, right? But this is a bit of a layman's language, a bit of as orthopedic surgeons, we are more interested in knowing as to what exactly is happening at the osteoarticular level. So at the osteoarticular level, flat foot is a condition in which the subtalar joint is stretched to its maximum limit of eversion. Now let's understand what I mean. Eversion and inversion of the subtalar joint are not as simple movements as they seem to be. So subtalar joint, have we covered biomechanics of subtalar joint in the first session, CTEV session? So it is more or less like a ball and socket joint, right? Like the hip joint, we have the femoral head, which is the ball, which rotates in the socket, that is the acetabulum. In the subtalar joint, we have the talar head, which is the ball, and the calcaneum, the navicular, and the spring ligament, they form the socket. And unlike the hip joint, where the femoral head, that is the ball, rotates in the socket, in the subtalar joint, it is the socket, that is the calcaneopedal unit, which rotates around the ball, that is the talar head. Okay? So, furthermore, the axis of the subtalar joint is not exactly either a sagittal axis or a transverse axis, but it is an oblique axis. The net result of this is, when we talk about eversion, eversion actually is a complex three-dimensional movement in which the heel goes into valgus, external rotation, and dorsiflexion. So eversion, the heel goes up and out. Inversion, the heel goes down and in. This is because of the, the complex arrangement of the axis of the subtalar joint. And it is very important to understand that. So flat foot, when I say that the heel is everted, it is in valgus, it is in external rotation, and it is in dorsiflexion. It is a three-dimensional movement. Now, having spoken about the, the pathoanatomy of the flat foot, we now come to the types of flat foot. And the first, when we define flat foot, we have to rule out any underlying pathology. So, flat feet can occur in the presence of underlying pathology, most commonly neurological problems like cerebral palsy, spinal dysraphism, or in conditions of excessive ligament laxity like trisomy 21. Now, this is a different category of disease which is to be treated differently, and we are not going to cover that in this particular session. What we are talking about is flat foot in the normal child, the neurotypical child. And these flat feet are basically of three types. That is flexible flat feet, flexible flat feet with tight TA, and third is a rigid flat feet. Okay. So first let's talk about flexible flat foot. Okay. So this child has flat feet on weight bearing, but the arch reconstitutes and the subtalar joint inverts on toe standing. So this is what I mean by flexible flat foot. The child actually has an arch, but when he weight bears, the subtalar joint everts and the arch collapses. So that is flexible flat foot. Another common clinical test which is used to diagnose flexible flat foot is do the Jack's toe extension test. So you do the Jack's toe extension test, the plantar fascia by its windlass effect, it will reconstitute the arch. So this is how you can identify that the child has a flexible flat foot. Another clinical finding that you have in flexible flat foot is that the subtalar joint is freely mobile. So how do you look, how do you check for the, the movement of the subtalar joint? You cup the heel in your palm and then you invert and evert the heel. And if that movement is free, you know that the subtalar joint movements are free. So these clinical signs tell you that the child actually has a flexible flat foot. Associated with the child may have generalized ligamentous laxity. So you should also check for ligamentous laxity in other joints. Now, what is the natural history of this flat feet? Okay, so this has been extensively studied, and we know that almost all the babies are flat-feeted. Almost all the toddlers are flat-feeted. Okay, but as they grow, as the age advances, the incidence of flat foot decreases. And by the age of adolescence, only about 20% of adolescents have flat feet. However, if the flat foot is flexible, most of them remain asymptomatic. So flexible flat feet, there are studies, population surveys which have been done, which have shown that almost 20% of the adult population is flat-footed. However, if the flat foot is flexible, then they don't have any problems throughout life. Okay? So this led to the famous aphorism by Lynn Staheli that flat foot is usual in infants, common in children, and within normal range in adults. Now we come to a second subcategory, and it is important to understand this subcategory, that is flexible flat foot with tight TA. And why it is important to recognize this? Because many times when a flexible flat foot is associated with a tight TA, it becomes symptomatic. The child experiences pain on the medial side underneath the plantar flex talar head, and also the child experiences pain on the lateral side at the level of the sinus tarsi. So what happens in a flexible flat foot with tight TA is all the clinical features that I mentioned previously in flexible flat foot, they are present. In addition, the child has a tight TA. Okay. Now the important question is, how do you check for the tight TA in a flat foot? So to check for the the tight TA, you have to first lock the subtalar joint in inversion and then dorsiflex the ankle. Why this step is very important is because if you fail to lock the subtalar joint and you just try to check the ankle dorsiflexion, remember that the subtalar joint also has some element of dorsiflexion. And the dorsiflexion which is actually occurring in the subtalar joint may then be confused for dorsiflexion of the ankle. So in order to check for the true dorsiflexion of the ankle joint, it is important that first lock the subtalar joint in inversion and only then check for the ankle dorsiflexion. Another important test that you have to perform is the Silver-Schule test, because this test will then tell you the difference that where is the tightness arising from. Is it an isolated gastrocnemius tightness, or is it a tightness of the gastrocnemius and soleus? Knowing this is important because, as we will see later on, even in the CP session, that this will guide our surgical management. If this child goes in for surgery, what is the choice of surgery that we are going to offer? That depends on the results of the Silver-Schule test. Now, contrast to flexible flat foot, rigid flat foot is a condition where the arch cannot be restored. Even when the child is not weight bearing, the child is going to be flat-footed. These children have restricted subtalar joint mobility. This is more commonly seen in adolescents, and the most common cause of rigid flat foot is a tarsal collision. And in tarsal collision, the commonest collisions are between the calcaneum and navicular, that is calcaneonavicular, and between the calcaneum and talus, that is the subtalar collision. And in flexible flat foot, there is no need to do X-rays unless the child is symptomatic. But in a rigid flat foot, always you have to do X-rays in order to identify whether the child has a collision. In a calcaneonavicular collision, what you will see on X-rays is a calcaneonavicular collision is best seen on the oblique view. And on the oblique view, you will visualize the collision, as you can see over here. My arrow is visible? Yeah, so that is the collision. Additionally, on the lateral view, you will see the anteater nose sign. Okay, so these two radiological signs you will see in case of a calcaneonavicular collision. In a talocalcaneal collision, it is difficult to see the actual collision, but you can see some surrogate signs. So one sign that you can see is known as the C sign of Latour. So that is one surrogate sign for a subtalar collision. However, mind you that this is not a very specific sign. Okay, subtalar, the C sign can be seen even in flexible flat foot. So this is not a very specific sign. So that is one sign that you have to look for in a suspected talocalcaneal collision. And the other sign that you have to look for is this spurring at the talar neck. Why this spurring occurs is because there is excessive stress, because there is no mobility on the subtalar joint, there is excessive mobility at the talonavicular joint, and that leads to this spurring that is occurring. However, the best way to diagnose a talocalcaneal collision is a CT scan. Okay. In fact, whatever be the talocalcaneal collision, whatever be the type of collision, you have to go for advanced imaging, that is MRI or CT scan, because that will tell you, give you more details about the anatomy of that collision if you are planning a resection, and also if it will tell you if there are any more collisions. Like you may have a calcaneonavicular collision, but in association with that, you may have more collisions. DD, there is not much, but the most important differential diagnosis for a flexible flat foot, especially in a toddler, is the congenital vertical talus, or more importantly, the oblique talus. Many times the oblique talus may be confused for a flexible flat foot, and we were just discussing this in the last session. How do you differentiate? So the sole is convex, plantarward. The talonavicular joint is irreducible, or in case of oblique talus, it is partially reducible. And the diagnosis is on the basis of X-rays, where the first empty axis remains dorsal to the talar axis and it fails to reduce on the plantar flexion view. So to conclude, flat foot is a position of maximum eversion of the subtalar joint. It is flexible flat foot is physiological in children, but its incidence decreases with age. With tight TA, the children can have symptoms, and rigid flat foot needs to be evaluated further with X-rays and advanced imaging. Thank you.
Thank you, Sandeep. You have definitely elaborated the pathoanatomy and classified flat foot.
Thank you.
Well, when you said there is a type which has got tightening of or contracture of tendon Achilles, can we say that these are the symptomatic flat foot which are still flexible?
So, what you are saying is perfectly right. Probably there is a subcategory of flexible flat foot which fail to resolve at adolescence, and additionally they develop tight TA, and these are the children who become symptomatic. So if in toddler age there are 100% children who have flat feet, by adolescence probably only 20% of them would be having flat feet. But even out of those 20%, only about 3 or 4% may have symptoms in the form of pain under the talar head and laterally at the level of the sinus tarsi. And most commonly, those who have pain, they have a tight TA. So probably the tightness is something which occurs secondarily and comes on, during the adolescent. That's why they become symptomatic at that age.
I would like you to overemphasize about the jack toe extension test also.
Absolutely.
Because many of them may not have become conscious of this very important test, where you have to differentiate in a very small child whether this child is having flat foot or not, especially in the light of the fact that newly born babies, they have pad of fat placed in the arch, which normally vanishes in about 2 years. Sometimes it may be even late. So this test is really very helpful.
Absolutely.
Right.
Yep.
You have rightly pointed out the various deformities and the coalitions that are present. There could be bony coalitions, there could be cartilaginous coalition. So how do we differentiate?
So in the presence of, strong clinical suspicion, so you have a symptomatic rigid flat foot, there is no subtalar mobility, yet your, X-ray is not showing any, signs of coalition. The only alternative is to go for advanced imaging. Now, even in advanced imaging, CT is considered generally the gold standard, but even CT, if the coalition is in the fibrous stage, but it has already become symptomatic, it may not pick up those fibrous coalitions. And therefore, there is some recent literature which suggests that, probably MRI in such situations can be helpful. So MRI will show you the fibrous coalitions, number one. MRI will also show you some bone marrow edema patterns which suggest that there is a lot of stress occurring at that area, which is the explanation for the pain.
Sandeep, I would also like to know, if there is an entity called spasmodic flat foot, and
so
then how do we proceed?
Peroneal spastic flat foot again is a terminology which has been used to describe painful flat feet. Though today's textbook, they don't really explain what exactly it means. But what happens in peroneal, so one cause of peroneal spastic flat foot is tarsal coalition. Another explanation is, when there is an inflammation of the subtalar joint, which can occur in either rheumatoid arthritis or infection like tuberculosis, etc. What happens is, for the subtalar joint, the position of maximum comfort is the position of eversion. And in order to draw that subtalar joint into eversion, the peroneal muscles, they go into spasm. And they go into spasm and they become painful. And so you get pain along the, the line of the peroneal tendon. And that, entity has been described. Though it is, it tells you what is happening. It does not tell you what is the exact cause of the flat foot. So that has to be investigated further.
Yes, thank you. Thank you very much, Sandeep. Well, friends, we are discussing flat foot in this scientific session. And I think flat foot has both the extremes. On one side is conservative treatment, on the other side we have operative management. And so in the conservative management, maybe many of the times we have to treat the guardians of the children than the patient themselves. So now the subject is open: conservative treatment and errors by none else but Dr. Ritesh Runu from IGIMS.
Thank you, sir. Respected and colleagues. Dr. Sandeep has very nicely elaborated on the flat foot causes and types. I'll be discussing about the conservative management of planovalgoid foot. This is a very common condition we usually see in our clinical practice. In a pediatric age group, child presenting with flat foot. Many a times it is a concern of parents, and most of the time I should say, and very few patients we get because of foot pain. That these patients are presenting with foot pain. मेरा बच्चा दौड़ता नहीं है या खेलने जाता है जल्दी चला आता है. So there as a physician we have to find what is the cause and how we are going to treat these patients. So in pace planners, we have already gone through the varieties, flexible and rigid type of flat foot. And one variety which Dr. Sandeep has highlighted, and it has been that compensatory flat foot that is due to tight TA. So in flexible flat foot, by simple examination, tiptoe standing, and by simply extending the great toe, we can find out whether it is a flexible flat foot or it is a rigid flat foot. If the arch appears and the patient is able to, and heel valgus has corrected. If you see here, both the heels are in valgus. But the moment child stands on the toes, that valgus heel has corrected. It has either it is in the straight line of the calf or it is in the varus. So it means it is a flexible flat foot. We have to quantify whether this flat foot is severe, very severe, or it is mild. For that, we usually use a few of the criteria. Taxan has highlighted a clinical criteria. A child is standing, it's a flat foot, and child is sitting, non-weight bearing. There is still the flat foot. The arch appears that it is flat. It is a severe type. The child is standing flat, but while non-weight bearing, there is no, that arch appears, it is moderate type. And if arch is present while standing or while non-weight bearing, it is a mild variety. Staley's index, there we measure the most narrow part of the foot in podogram, that is the midfoot, and we divide it with the widest part of the heel, that is, this is Staley's index. And normal is less than 0.5 to 0.7. Another criteria which is more accurate, that is Tipok-Smirak index. Here we divide the most narrowest part of the foot on podogram from the widest part of the foot, that is the forefoot. And from this we can decide what is the grade of the flat foot. Already we have discussed about CVT and other rigid causes of flat foot. So in CVT, we discussed about the casting technique, that is one of the conservative method of treating the congenital vertical talus by Dobbs technique or reverse Ponseti technique. And when we fail, then we go for surgical treatment. In tarsal coalition also, we can try with the conservative management. If these patients present with painful foot, and after diagnosis by X-ray, CT scan or MRI, if we come to know it is a tarsal coalition and patient is having painful foot, they can be well treated by cast, Biloni walking cast, and we can extend this casting session as long as the child is painful. And gradually we reduce the duration of cast, lesser duration of cast, and longer duration of cast-free period. And as this child grow up to the adult, and as they cross or reach near the 20 years of age, their pain is well under control, they don't need any surgery in these patients. And in some patients, we need to apply some braces or corticosteroid injection in the painful area to relieve them from pain. And most of these patients are treated by conservative management. Only few patients having persistently painful foot, they require surgical intervention. But all cases do not need surgery. There should be in the mind that most of them can be treated by conservative management. The modalities of conservative management are variety of management. We have options like exercises, insoles and inserts, casting technique and injections. If you see that there are a variety of exercises, but the most important principle and what we are trying to achieve from the exercises, it is the strengthening of the muscles. Strengthening of the muscles which are working in the foot, and these muscles, intrinsic and extrinsic muscles, they basically support our medial longitudinal arch. And when this arch is supported by the muscles, already we will be able to recreate the arch, or the pressure on the medial aspect of the foot because of flattening of arch will be reduced. So there are variety of exercises. You can see that toe extension exercises by this. Second is toe curls. Just we are trying to grip the towel with the feet, and the role of exercises has been emphasized in the paper by Rao and Joseph. They studied almost around 3,000 kids, and they found that the kids who were barefooted, not using shoes, they have a very good arch development compared to the kids who were using shoes continuously. And it signifies that exercises of the foot has a role. Here you can see that stretching exercises of the muscles of the foot. Second is toe extension. Then stretching of the tendo-Achilles, because many a times tight tendo-Achilles leads to flattening of the arch. And dynamic stabilization by intrinsic and extrinsic muscle groups gives a support to our medial longitudinal arch, and thereby we are able to manage these flat foot patients. For tendo-Achilles stretching and plantar fascia stretching, these are the exercises. Now there is some role of insoles and inserts also in patients who are having painful foot. They are having flat foot, but it is also painful, flexible flat foot with pain or weakness of the muscles. There we can apply insoles and inserts. You can see that by using the insoles, the heel which was going in valgus, medial arch was dropping down. We have just elevated the medial arch, and the insoles and the alignment of the foot has become straight. Now the pressure over the medial aspect is reduced. But these insoles, it doesn't recreates the arch permanently. It is only momentary till the arch is there or insole is there. It is recreating the arch, but it doesn't help the arch to reform. So Wenger et al., they found in their study, they divided the patients in 4 groups, and they found that wearing corrective shoes or inserts for 3 years, it does not influence the course of flexible flat foot. So it gives momentary relief to the foot with pain. It corrects the arch, corrects the foot mechanics, but it doesn't recreate the arch. So in these patients, barefoot walking and playing activity helps in medial longitudinal arch development in the child. This arch develops by 5 years of age, and by 10 years of age it is fully formed. So before 10 years of age, we should not think of just giving any type of insoles or inserts or special types of shoes. We should give the child some time to develop their own arch. Painful flat foot needs assessment and intervention. We should not discard these patients. This is flexible flat foot, इसमें तो थोड़ा दर्द रहेगा. Even if it is flexible flat foot and painful, we should intervene and we should investigate these patients. Flexible painful feet needs insoles and inserts for treatment of pain. These insoles helps in momentary correction of flat foot, and exercise helps in muscle stretching and strengthening. So we should focus on exercise also. Thank you.
Right, Dr. Renu. Thank you. Usually accompanied by their parents, would you prefer to examine their feet also?
Yes, sir. Not parents are also having flat foot in few of the patients. Not always. Only 2 or 3 patients I have examined, not all the patients, but I have found that the father was having flat foot, the child was having.
It could be any permutation and combination, but I think there is no harm
Only 3 patients I have seen,
if
sir.
you
But
examine
it's
the
not a
parents
regular.
as well. And number two, the knee joint is one joint which must be examined also when you are examining a patient of flat foot, and each one of us are aware of it. You have very rightly highlighted that for tarsal coalitions, the next presentation will deal with it, may not require surgery in all cases. Thank you very much.
Thank you, sir.
We must talk now about the surgical management, because that is the due time now.
Yeah, most of the orthopedic surgeons are interested in the surgical treatment, so this lecture is very important. Can be divided into 2 categories for the understanding the treatment point of view. The one with a normal length of tendo-Achilles, where there is no shortening of the tendo-Achilles, and the treatment of that is already covered really well by the previous speaker. Then we have a condition of a flexible flat foot where the tendo-Achilles is short. And then we have a third category which comes into this category where there is a accessory navicular bone. I'm not sure whether what is the relation of accessory navicular bone with the flat foot, but it's always described in this chapter. So the last 2 conditions usually or sometimes require surgical treatment. I would say sometimes require surgical treatment. On the other end, we have a different variety of flat foot where there is a loss of subtalar movement and which is called a rigid flat foot. There are various reasons for that, and Sandeep explained us really well that it's a broad category and ultimately there is a loss of subtalar movement. So all that are grouped into one category, that's a rigid flat foot. So tarsal coalition is one of them. The inflammatory conditions or rheumatoid conditions, they also produce pain of the subtalar joint, and patient involuntarily reduce the subtalar movement, and that's why it's called rigid. There is no bony connection between the tarsal bones, but because of inflammation, there is pain in or painful movement of the subtalar joint that results into rigid variety of flat foot. Infection will definitely lead into this category, and very rarely tumors will also produce pain, and that would produce rigid flat foot. All of them, they required surgical treatment. So no doubt they are small as far as the incidence is concerned, but they required surgical treatment. Now let's come to the first, the flexible variety where there is a short tendo-Achilles. It's likely to be painful because why it is likely to be painful that we will see the next. But the surgical treatment is tendo-Achilles lengthening, a very simple surgery, and I'm sure that everyone sitting in this hall can do it confidently. But the important point that when parents come to us for the flat foot, they have 2 components. The one is pain, the second is appearance. The tendo-Achilles does not take care of the appearance part. So we really need to make sure that why they are preferring for surgery or why they are going for surgery. And if appearance is one of them, then we need to carry out anterior calcaneal lengthening along with tendo-Achilles lengthening. Very few of you will be familiar about anterior calcaneal lengthening, so I will explain you the concept of that. And if required, tomorrow we will see the surgical video of that procedure. So first of all, let us understand that why short tendo-Achilles leads to pain. So this is normal foot. Now here the tendo-Achilles is short, and when this child is walking with the short tendo-Achilles, ultimately the foot or forefoot comes into contact, but over a year this results into a break of the midfoot, and that results into the eversion of the subtalar joint. So it's a 3-dimensional deformity, but if we look at from the side, there is a, like this is normal alignment, and this results into a break of the talonavicular joint or navicular cuneiform joint. And this is where the things go wrong. If we look these children from behind, we can see the valgus hill. And this is how the X-ray hindfoot view looks like. If we look from the top, this is normal, where we saw that the talus and the first metatarsal are in the same line. But here, the another component, the three-dimensional component is the forefoot is abducted. Now, to understand the procedure, that's the lateral column lengthening, or Mosca's procedure, or anterior calcaneal lengthening, all are same, different name to the same procedure. To understand that, let's see that if we look at this foot model, I have divided the tarsal and the metatarsals into two components. The fourth and the fifth, they are called lateral, which are in a blue color. And the medial one, which are three, they are in green color. So which column, medial or lateral column, is long? Medial column is long. Good. So now if we want to correct the deformity, we can either shorten the medial column or we can lengthen the lateral column. Right? So if we see these two fingers, if they are different height, different length, either we can lengthen the short one or shorten the long one. The procedure which is very popular over here in the pediatric foot chapter is lengthening the lateral column. So we will understand the concept behind that procedure. So this is what the foot model which we already see. Now we carry out a osteotomy at the anterior end of calcaneum, which is around 1.5 to 2 centimeter behind the calcaneocuboid joint. We cut the anterior portion of calcaneum. Now we are looking at the calcaneum and where we carry out this osteotomy. If we look at subtalar joint, we remove the talus and then we look at the upper part of the calcaneum, we see a three facet. The anterior facet, medial facet and the lateral facet. And this osteotomy is carried out between the anterior and the medial or the medial facet. This is where the osteotomy is carried out. So it's an intra-articular osteotomy for the subtalar joint. We are looking now from the side, and this is where we have cut the calcaneum. Now, understand the principle. After this osteotomy, we pass a wire through the calcaneocuboid joint so that when we open the osteotomy, no displacement takes place at calcaneocuboid joint. Once we have fixed that, we carry out or we apply a medial force or adduction force, and that results into opening of the osteotomy. Whatever gap has resulted, that we put it with the bone graft, either from iliac crest, from fibula, or in cerebral palsy where we have done a distal femur osteotomy, we can use femur also. But usually we prefer iliac crest graft. And then we advance the wire which is fixing the calcaneocuboid, now it fixes the osteotomy. So now if you look at the foot is well corrected. After correcting the foot, we check the length of the calf muscle as described by the Sandeep, with the knee extension and with the knee flexion, and we realize which one is short. If it's a gastroc only or both, usually in flat foot, it is calf muscle, both soleus and the gastroc are short, so we carry out tendoachilles lengthening. So we are not going into that, but that's the full dose of treatment which we need to give for a flat foot with short tendoachilles. Don't do isolated tendoachilles lengthening because that may take away the patient's pain, but family will be unhappy that the foot is still of the same appearance. Coming to the accessory navicular bone which requires surgery, which is not really very difficult for any one of us. We make an incision on the prominent navicular and then we excise that navicular, taking out the soft tissue covering, and once we take out the bone like this, we suture the soft tissue coverage. We don't need to carry out a complicated procedures for transferring the tibialis posterior or like that. So these are the bilateral procedure where we remove the prominent navicular. this is again for two reasons, because it is producing the pain, the pressure pain on the prominent navicular, so we need to carry out that procedure. If there is no pain, there is no need for surgery. And then we coming to the last part, that is excision of calcaneonavicular coalition. Sandeep has shown some pictures, but I will try to explain in some more details so that you get more confidence in dealing with this condition. Again, it's not that difficult. So this is the calcaneonavicular coalition, CT scan. We need to take out, first of all, indication when there is an activity-related pain around sinus tarsi area. Because with activity, we need a subtalar movement, and navicular and calcaneum cannot move with each other, so it produces more load at other joints, and that produces pain around sinus tarsi. Usually, we try all the treatment which Dr. Ritesh explained, non-operative treatment. And if we are not getting any relief with this treatment, then it becomes an indication. Just we saw the coalition on the X-ray or CT scan, that does not become an indication for this surgery. Sometimes they have a pain on the medial aspect of foot, which is around talonavicular area. The oblique incision over the sinus tarsi, we elevate the extensor digitorum brevis from the sinus tarsi like this, and that will expose the coalition. Once we identify the coalition, we need to define the proximal and distal border, and then we need to use a osteotomy which is of around 1 centimeter size, and we need to cut at lateral side and like this. So we need to take out 1 centimeter of bone from that, so that separates navicular and the calcaneum. This is what the picture of surgery, where we can see the gap, like you can pass a finger and see that it's completely corrected. It's very important that we take out the bone coalition of the full depth. And after putting the finger, either little finger or index finger, depending on the size of finger, we have to ensure that we have corrected the complete coalition. Usually it is of this much size. Once we remove it, we need to cover the raw area with the bone wax, because it's a cancellous bone and it's likely to bleed. Then we can fill the gap with either fat, which is taken from the buttock area or from the proximal thigh, or suturing the extensor digitorum brevis in the gap. But usually it is better to fill the gap with the fat so that the chances of recurrence are less. And then we give a plaster for soft tissue healing for 3 to 4 weeks. So this is what the picture which shows that this is the coalition, and this is the picture taken at the time of surgery, where we can see that there is a complete discontinuity between the navicular and the calcaneum. And this is the post-op picture of the same patient. So the take-home message is, there are 3 common conditions which require surgical treatment in the flat foot variety. And I have tried to make it simple so that you can carry out these procedures with confidence. Thank you.
Thank you, Dr. Presentations. Things look so easy to perform. But friends, remember, it may not be so, and your clinical examination, your clinical judgment will be so very much important. Dhiren, I'm so happy you have done thorough justice to the 3 procedures that you have described. I am in a way happy that you have not talked about subtalar arthroresis. And when I was entering, I was looking for whether there is a stall keeping an arthroresis implant. So it was not there. Well, in very many countries, it is so familiar that people know that treatment, surgical treatment in pediatric flat foot is putting an arthroresis implant. Well, there are controversies, but there are good results as well. Your anterior calcaneal osteotomy You said Mosca's procedure. Yes. Well, talking about calcaneal osteotomies, it is done for even CTEB, even for other purposes. And I would like to mention name of Professor S. Pandey, who uses a T osteotomy for correction of clubfoot also, and it can be varied for correction of the other deformities. This surgery uses only one vertical part of the T, and you have nicely demonstrated how it can be contemplated. What I would like to know from you, calcaneal osteotomy behind also is one procedure which is widely practiced. Any reason, time, because of paucity of time you did?
Tomorrow, we have a session on sagittal deformity correction.
All right. Or we will skip discussion?
Then case with discussion by Dr. Shodav Chaudhary. Good afternoon, everybody. Thank John sir and Jaswinder for inviting me here. I have two cases to present. The first case is a 13-year-old male who has activity-related pain on the medial side of the midfoot for 2-3 years, and he has some issues with footwear also. He has bilateral pain, and left is worse, and there is a history of frequent falls while playing. Clinically, the subtalar joint is practically quite stiff. Talonavicular movements are severely reduced, and tendo Achilles appears to be contracted. These are the clinical pictures. As we can see from the backside, the heel is in valgus. On a single leg stance, there is a fall in the arch, and there is a quite prominent talonavicular joint over there. And in the front also, the foot looks flat with prominent talonavicular joint. These are his X-rays. Anybody would like to comment?
Are they weight bearing?
No, they are not.
So I think
I
weight bearing
apologize for
is.
that. Yeah, weight bearing is better. This case was.
So there is a coalition in the calcaneal navicular.
Yes. So there is a calcaneonavicular coalition, and there are degenerative changes in the talonavicular area also. Probably that is the reason he is having. Exactly, osteophytes on the navicular as well as on the dorsal side of the talus. So what are the options in this case? Anybody would like to opt for a conservative management for this case?
Trial of conservative.
He has had therapy and some inserts for 3 years, and he is
just
not
below knee cast application for 6 weeks.
With all these osteophytes and such restricted motion as well as TN changes.
As I said, I'm not sure whether they are osteophytes. I mean, it's very rare to get true degenerative osteophytes in a adolescent boy. These are actually spurs which occur due to excess strain on the talonavicular joint, and they occur on the talar neck. I mean, they are more of an extra-articular, they are due to stripping of the periosteum at the level of the talar neck. So they should not be, assumed to be indicators of osteoarthritis. The joint space looks quite okay, so I don't think this is osteoarthritis, but definitely, I mean, this requires treatment. Yeah, so.
Your concern is that the child has repeated falls.
Repeated falls also, right from the beginning? Yes. Apart from the pain.
It has not been prevented by.
Last 2-3 years he has had constant pain, and he has seen multiple doctors, and they have all advised insoles, which is of no help.
So at this age, what is the cause of recurrent falls?
Not at this age. He has been having it right
Okay.
from the early childhood.
Okay, so
that is what I said. I have a CT.
So no other coalition, apart from this.
No, there is no other coalition. I have not put the CT here, but.
One important point, when we have one coalition, that does not mean that there are no other coalitions.
I understand.
Always we need to go for
CT scan, yes.
A trial of below-knee cast would be given this way.
All right, okay.
That gives the rigid immobilization to the strained joint.
So for a 13-year-old child and who has been having symptoms for 3 years and who has had all the orthotic treatments.
Still in coalition cases, we need to go for a below knee cast.
Okay.
So there is an element of muscle imbalance and some muscle rebalancing may have to be required. Is this what you want to emphasize?
Where is the pain actually?
Medial side of the foot. Medial side of the foot.
And he's got the classical rigid.
Yes. In fact, he has some amount of ankle laxity. So if he stands on his heels up, you can see some amount of inversion. Probably that is happening at the ankle. So again, I went on with the surgical treatment. I removed the coalition part. And then I did after that I could see that the talonavicular joint is still mobile. So I could move the medial arch, and I thought appearance wise also we should add some other procedure. So I did a calcaneal lengthening and grafted it with locally harvested fibula. Those wires are for retraction. And actually when you do this lengthening osteotomy, you have to pass a wire across the cuboid into the front part of the calcaneum before you distract, because then the joint will not sublux. And then you pass it across the graft into the proximal calcaneum. And this is this is not a weight bearing X-ray. This is very early actually in the follow-up. This is just 10 months now. And then he has gone to Delhi for his studies, and these aberrations are because of some playing incident. So these are what he has sent on WhatsApp to me recently. So some reasonably looking arch, and he is able to do all his activities. These are the pre and post laterals. So there appears to be some improvement in the talocalcaneal and calcaneal pitch also, as well as the talo first metatarsal angles. Overall, parents and patient is satisfied with the procedure. So I would just like to know any comments.
Pain is fine.
Pain is fine.
How much lengthening did you actually achieve?
It was about 1.5 centimeters of fibula, this thing, yeah. Yeah. Post-op X-ray is not oblique, so that length will not be properly visible in that. Yes, that is the fibula there.
So only I would ask the other faculty, what are the indications for deformity correction along with your bar excision, and would you do it at the same stage, or would you stage it a little later?
Yeah, very good question, Sandeep. I have done that mistake of doing both the things together in one stage. And it has been mentioned in the textbook. Fortunately, I did not have any complication, or like he did not have any complication. But the literature says that please don't combine both the procedures, because soft tissue healing is not really good in this area. So I was just going to point that you are really lucky that there was no healing. Or in my case also I was lucky, but ideally we should not combine both the things together.
Sir, Dr. Mosca, he shows to be combining both of them actually in one go.
So that's where you have to be very careful as to where the pain is localized. Now in his case, he was a calcaneonavicular coalition. If the pain was because of the coalition, excision of coalition would have been fine. But in his case, I feel the pain was on the talonavicular joint, which indicates that the pain was also because of, stress on the talonavicular joint, which is due to the flat foot deformity. And therefore, in his case, the flat foot deformity correction is indicated. The only question is whether it should be done at the same sitting or at a later sitting.
What do you think, sir? What is your practice?
I would probably do it at the same sitting, because, it is difficult in our setup to, get the patient to come back and,
The other thing
and
is,
if the pain doesn't get relieved after your bar excision, they are going to be unhappy.
If you say the reason for doing it in one stage is that it's difficult to get the patient to come back.
They are going to be unhappy.
Can we do only anterior calcaneal lengthening, because your pain is located at the medial side, not at the anterolateral at the synchondrosis side?
No, but the stress at the talonavicular joint will remain then. If you don't restore the mobility.
But there is no pain, sir, and it will not move.
It will not move. Unless and until you separate the calcaneal and navicular.
The stress will remain there.
No, correction will not take.
There won't be any motion. Not move.
Other thing is, Dr. Hello. Dr. Mosca has always said that combining this with a cuneiform osteotomy, that is what I was asking. So, because the supinated to Mosca osteotomy. 4 foot.
Plantar flexion, wedge
So to
osteotomy.
correct it simultaneously, because of the wriggling pattern of the foot, one deformity goes into supination of valgus, the other goes into pronation.
So that is the last decision to be taken after this osteotomy. Some cases the forefoot or the medial column will actually be flexible. In those cases you don't have to add it simultaneously. You're talking about a fixed, yeah. Second case is of another 12-year-old male who had medial midfoot pain again, and he had prominent footwear issues. His feet used to hurt when the shoes, and there is a prominence of talar head and restricted ankle movements and subtalar movements. These are the clinical pictures. This is only on the right side. You can see that the talar head is quite prominent here. And on standing on tiptoes, there appears to be some amount of inversion occurring there. These are his x-rays, again non-weight bearing. This was referred to me and I didn't ask for weight bearing x-ray because I straight away went for the CT. So talus is
we need better imaging because we are not able to understand the pathology clearly from this.
exactly. So probably the CT will be able to show it better because even in lateral, this lateral is taken adequately. It's not weight bearing, but it's difficult to visualize the talar neck and where the navicular is sitting. So on the CT there seems to be a small coalition over there, and these are the 3D images. There is a small coalition between the talus and the calcaneum on the posterior side, posteromedial side, as well as there is a complete dislocation of the navicular. Navicular is sitting on the neck of the talus. So it's a it's a combination of CVT and it's painful. Pain is mostly at the TN actually. Medial side, predominantly the navicular, talonavicular area. Yes. Yes. That is the area where it's happening. So in the middle image actually you can see the talar dome is totally uncovered. It is lying in the front and the head is entirely down. So again options. Anybody would like to offer conservative? 12 years.
Triple probably is.
Because in these patients might be calcaneal dysplasia also.
And get the corrected.
Because another point that is to be considered is the quality of cartilage in the subtalar joint, which in this case is likely to be poor.
Very poor.
So there is no point in excising that bar and attempt to get any motion at the subtalar joint.
Navicular is gone.
Yeah.
So, okay. Any other differing opinion?
What is the age of the patient? 12?
12 years old, sir.
I would like maybe to wait for some few more years for the skeleton to mature and would prefer going for a different kind of pan-talar arthrodesis in which this is, yes, ankle as well, yes, because of the advantage that you take out the talus as a whole. This is a classical paper from Professor Sureshwar Pandey, and he removes the talus and removes the articular cartilage all around and puts it back into the corrected position. And when they unite, it's a good plantigrade foot and definitely is painless.
So something like a morselization.
Oh yes.
But he does that in younger patients.
Younger patients as well.
Can we see the midfoot also in your experience? Because it's not only the hindfoot.
Remember he said his lower age limit is 8 or 98.
Tarsometatarsal joints are reasonably aligned if you lateral view. So it's a dysplasia over in that area, and it has remained all throughout, so the morphology is different. So I did a navicular excision and reconstruction with a dual incision. I released the tibialis posterior, lengthening of tendoachilles, peroneus brevis, tibialis anterior, and certain capsular releases, especially the posterior ankle release, because the talus wasn't going up into the ankle properly. Probably the space was created under the talus, so even the heel inverted and calcaneum came down. And since the talocalcaneal joint was of very poor cartilage was there, so I opted for a fusion. Whatever navicular I had removed, I removed the cartilage and I put it back into the talocalcaneal space. And Timpos was advanced to cuneiform, and KOS was applied to hold the position. So I have preserved the navicular, yes. Pardon me? It's not a triple. I have not done a triple. I have treated it as a neglected case of CVT, where naviculectomy is the advised treatment along with the soft tissue reconstruction. And in the process of doing that, the coalition broke off.
But navicular cuneiform also has been buggered also. Navicular
Yes.
because it's like in triple we are damaging three
So
joints.
whatever little movement he has, I have another option of going back and fusing it later, if at all.
That particular movement also become painful in due course because of that stress would be borne on that joint.
So a triple would remain painless for how long? Like even that time, that also will degenerate over a period of time.
It will remain sometimes. Always there are wherever we do about excision of the joint, it will bugger the two joints, proximal and
Yes.
similar for talectomy also. So that is the reason talectomy long-term result also has been having the painful. So the people
Yes.
have moved away and tried to view for fusion between tibiocalcaneal fusion actually. Whenever you do the talectomy and the fusion. So that's why it's been combined with the fusion. So here if you take out about navicular, it will have a lot of stress on the both sides. Either
So
side.
navicular wasn't in a good position to begin with, sir. It was not articulating with anything relevant.
So, but once you got the talus position, you might have been able to use that.
At least some bond would be there.
So fusing the talus with the cuneiforms. Navicular is out. There is no.
Don't take it out.
There is no space where the navicular will remain, if at all. I mean, naviculectomy is the standard treatment for CVT in a 12-year-old. There is no way that the navicular will go back.
So create a space, maybe initial just could have been helpful prior to your surgical exercise.
Sir, the cartilage hasn't been articulating well. The navicular is articulating with the talar neck for all these years. So even creating the space and putting it there. The cartilage was bad. Quite bad.
And cuneiform?
Cuneiform cartilage was still okay. But it was not, it was misshapen. It was not in, with a misshapen cuneiform, but cartilage is okay. Probably I am saving that joint for another 6-7 years maybe.
One point that you have made it very clear that tibialis posterior is the dynamic muscle force which you have transpositioned to the cuboid, right? So this one requires attention sometimes.
So these were the intra-op images. This is how the foot looked at the end of the procedure. Again, this was done just last 10 days back, so I don't have the long-term follow-up. These are his comparative images, and post-op angles look to be better.
Session in this session only we have a small video. Dr. Sandeep is playing that.
C osteotomy. The triple C osteotomy is a combined calcaneum, cuboid and medial cuneiform osteotomy described by Mubarak and Rajan for correction of planovalgus deformities of the foot in children. The indication for this surgery is a flat foot which remains persistently painful despite an adequate trial of conservative treatment. In this video, we discuss the surgery being performed on a 15-year-old male with painful flexible flat foot and tight tendo Achilles. The child is experiencing pain along the medial border of the foot under the plantar flex talar head. Preoperative weight-bearing radiographs of the foot show all the radiographic parameters of flat foot. The first part of the osteotomy is the posterior calcaneum displacement osteotomy. This is a pure translational osteotomy in which the heel axis is aligned with the tibiotalar axis by translation of the distal heel fragment. An oblique incision is made posterior to the lateral malleolus. The peroneal tendons are retracted anteriorly. The periosteum is incised and elevated, and the incision is deepened down to bone. Homan retractors are placed on the dorsal and plantar surface of the calcaneal tuberosity. The osteotomy commences at a point 1 centimeter behind the posterior limit of the subtalar joint. From here, the osteotomy extends obliquely at an angle of 45 degrees towards the plantar surface of the calcaneum. In the horizontal plane, the osteotomy is parallel to the plantar surface of the calcaneum. The osteotomy is performed initially with a saw and then completed with an osteotome. Care is taken to avoid injury to the posterior neurovascular bundle which lies on the medial side. The periosteum on the medial surface of the calcaneum is stripped in order to adequately mobilize the distal heel fragment. Following this, the distal heel fragment is translated laterally by about 1 centimeter. This realigns the heel fragment axis with the tibiotalar axis. The second part of the osteotomy is the cuboid lateral open wedge osteotomy. Incision for this osteotomy is made transversely overlying the cuboid. The extensor digitorum brevis origin is elevated. Homan retractors are placed on the dorsal and plantar surfaces of the cuboid. Osteotomy is made in the mid portion of the cuboid parallel to the calcaneocuboid joint. The osteotomy is opened laterally by inserting a lamina spreader. The third part of the osteotomy is the medial cuneiform plantar closed wedge osteotomy. To perform this osteotomy, a transverse incision is made overlying the medial cuneiform. The tibialis anterior is retracted dorsally, and Homan retractors are placed on the dorsal and plantar surface of the medial cuneiform. A plantar based wedge is then removed from the body of the medial cuneiform. The medial cuneiform osteotomy is then closed and fixed with a K-wire. The wedge obtained from the medial cuneiform is then inserted into the cuboid osteotomy. The wedge is then inserted into place by hammering with a punch and hammer. The calcaneum and cuboid osteotomies are fixed with K-wires. If there is an associated gastrosoleus tightness, it should be addressed by performing the appropriate muscle lengthening procedure. Postoperatively, a below-knee slab is applied, which is then changed to a cast at the first postoperative dressing. The cast and wires are continued for a period of 6 weeks, following which they are removed. Following cast removal, the child is kept non-weight bearing for further 4 weeks and AFOs are applied. At follow-up, serial X-rays are made which confirm good radiological and clinical correction of the deformity. Studies have shown good clinical and radiological outcomes with the CCC osteotomy. To conclude, the CCC osteotomy gives good radiological and functional outcomes with results comparable to those in literature. Thank you.
Cranial osteotomy, a low, if ever.
So these adolescent, and in these cases, I think, I would do the complete triple C osteotomy. There are some cases, like, the isolated posterior calcaneal displacement osteotomy. It is described in younger children in cases of heel valgus seen in spina bifida. But apart from that, the older children, probably I would go for the triple C osteotomy. Just before we move ahead, one more point I would like to just mention over here, that there is a criticism regarding the triple C osteotomy, that it doesn't correct the actual talonavicular, uncoverage at the level of the talonavicular joint. It just, creates deformities proximal and distal to compensate for the deformity of the talonavicular joint. So that is one criticism which Moshka always does, and he, propagates his osteotomy. But the problem that we have seen sometimes with the Moshka's osteotomy is that on long-term follow-up, there is some collapse of the arch that again happens. We do lose some correction which we have attained at the primary surgery. Yeah, CLO.
Also in the same sitting, if it is.
Yes.
Since we come to the end of this session, may I request Dr. Ritesh Runu sir to felicitate our chairperson, Dr. S.S. Jha sir. Ritesh. Thank you, sir. Dr. Jibendu sir, आप ही. Dr. Jibendu sir. Dr. D.K. Sinha sir. And Dr. Vikas. To the last session of today's CME, and may I invite Dr. Arvind Gupta to moderate this session.
So this is session 4, that is neuromuscular disorder. May I request Dr. Subhash Chandra sir to please come on dais. Dr. Janki Saran Badani and Dr. Ritesh Renu sir, kindly chair the session. Thank you.
Kindly also join the chairs.
Dr. Saurabh Chaudhary, please come on the dais.
Yeah, good evening. Hello, good evening, everybody. Now we are going to start a neuromuscular session, and the first talk will be by Dhiren Ganjwala sir. He'll be talking about a spastic foot and ankle in cerebral palsy.
Children coming to us for an opinion, and many of them are walking with equinus, and we have a temptation to carry out a surgical treatment. Fine, we are surgeons, and naturally if we have a desire and the keen interest in surgery, that's always good. I want to convey one important point in this presentation. We all know that spasticity is exaggerated velocity dependent stretch reflex. Means when we stretch the muscle rapidly, it causes or it goes into contraction. That is what the spasticity is. So there are various spastic foot deformities. The most common one is equinus. The second one is varus, where the forefoot and the hind foot, they go in varus, or a valgus deformity, and very rarely we have calcaneus. In the remaining presentation, I am going to focus only on equinus deformity. Equinus deformities are of two types. The one is, we call it functional or a dynamic. Means when child is relaxed, when child is lying down on an examination table, and we look at the ankle joint range of motion, there is a normal ankle range of motion. But the same child, when is upright, standing or walking, there is an exaggerated tone in the calf muscles, and that results into equinus deformity. So that's a dynamic deformity. The important point, please don't carry out surgical treatment in dynamic variety. Then there is a second group where even when they are relaxed, when they are comfortable in a lying down position or even sleeping, if you look at the range of motion of the ankle joint, the ankle does not dorsiflex fully. Means now there is a contracture of a calf muscle. And yes, they are the candidates for surgical treatment. So now the problem of equinus, the first of all, why we really need to treat equinus. Basically, when child is walking with equinus, the child is walking on only the forefoot, and that creates a very small base of support. Already these children have a balance problem, the cerebral palsy children have a balance problem, and if they walk with equinus, Hitesh, then it reduces the base of support and makes a child difficult for walking. The second, when they walk only on the forefoot, the whole body weight comes on the forefoot, and that results into broadening of the foot. The heel remains small and the forefoot become thick and broad. It leads to midfoot break. We will see that when the child constantly walk with equinus, ultimately the body tries to have a heel contact, and that results into a midfoot break deformity. Occasionally that leads to recurvatum at the knee joint. And if it's a unilateral case like a hemiplegic cerebral palsy, then the foot which is, or the ankle which is in equinus, will have a functional longer length, and that leads to limb length discrepancy. So the long-term effect of spasticity is ultimately it results into muscle contracture. So initially the child only have a functional variety or a dynamic variety, but over a year, years it becomes a contracture. Non-operative management options to us are a stretching exercise, which we recommend to carry out with physiotherapy or even at home. We can give them orthosis, which restricts plantar flexion and allow the child to walk in a plantigrade position. We can give a stretching brace, which they apply at night, so that when they are sleeping, the calf muscle is stretched. Or we can give them a cast. Or the last option, which is before few years was very popular, that was a botulinum injection, but now that has gone out of fashion. So stretching exercise are basically that ultimately the parents have a very limited time, and the major constraint of that is time, because they cannot carry out exercise for 8 hours in a day. That is what some people say, or some reference says that if you stretch the muscles 8 hours a day, then you can prevent it becoming a contracture. But no one in this busy life has 8 hours with them for exercise. So this is another option, the stretching splint. So it's a above knee splint, which has a very flexible portion at the heel, and we have a strap to take the foot into dorsiflexion. So these straps, when tightened, it takes the foot into dorsiflexion, and the mechanism can be seen. This is, the red one is a calf muscle. We need to go above the knee joint, because calf has a component gastroc, and it originates from above the knee. So we need to, if we effectively want to stretch gastrocnemius, then we have to use above knee splint. So this is, green is a splint. It keeps the foot in this position, and then with the steps, it takes the foot portion into dorsiflexion, and then it gives a stretch to the calf muscle, which usually child uses at night time. So they have 6 to 8 hours of stretching. My experience is that if this splint is effectively working, the child will not use this brace for more than 2 hours at night. They will get up and then they will cry and tell the parents that please remove it. But that tells us that yes, this splint is working. For those who are not following the suggestions, the stretching plaster is one option. Under anesthesia, we stretch the calf and then we give a plaster, keep it for 3 to 4 weeks. It's very effective treatment. The only negative point is that because we are immobilizing the ankle joint, it will create wasting of the calf muscles. Already in cerebral palsy, the muscles are weak, and we increase the weakness. Botulinum neurotoxin is a locally acting treatment. It's a locally acting paralyzing agent. To understand the mechanism of action, this is a neuromuscular junction. The upper one is a nerve fiber, and the lower one, the striated skeletal muscle, and the blue one is a neuromuscular junction. When the signals comes like this, the vesicles which contains acetylcholine are released in the neuromuscular junction, and that causes the muscle to contract. Now when we give botulinum injection, it spreads, it's given in the calf muscle, it spreads to the neuromuscular junction, to the nerve terminal. And look at, this is the neuromuscular junction membrane which is fenestrated. Chemically, it is converted with the injection into an impermeable membrane. So now acetylcholine cannot enter into the neuromuscular junction. And because there is no acetylcholine, the skeletal muscle will not contract, and we can say that it's paralyzed. So what happens now with the nerve signals? The acetylcholine vesicles will not enter into the neuromuscular junction, and it will not cause contraction of the muscles. This treatment, once very popular, but due to variety of side effects, now it is going out of fashion. So we are not discussing more about that. But let me tell you, in spite of the base treatment, all the treatment which we discuss, ultimately over a period of time, the contracture develops. And at that particular point, the child requires surgical treatment. Now, I am sure that the surgery is very easy. The only point which we need to remember, that I will clarify. So, looking at this leg and foot, we have two muscles. The one is soleus, the second one is gastroc. The difference between the two is soleus is originating below the ankle joint, while the gastroc originates above the knee joint. And then both these muscles have a common tendon, which we call it tendoachilles. Tendoachilles is a very popular surgery, and everyone can do it easily in 15 minutes time, not a problem at all. So when we do a tendoachilles surgery, Z lengthening, we cut the tendon in a Z manner. And once we cut, the proximal and the distal portion of the tendon will become separate, and we will be able to correct the equinus or the ankle deformity. That will restore the length of the calf muscles. The point which I would like you to remember, everyone in this hall, please remember that please don't carry out tendoachilles surgery in a diplegic children. Why? I will explain that. We saw that there are two muscles which are very close by. One is soleus, the muscles originating below the knee joint, and the gastroc. Now in diplegics, means when both the lower limbs are affected, they have more problem in the gastroc muscles, which is a biarticular muscles. So that I have shown as a red. Their soleus is normal, which is I have shown in a green. Now, when we carry out a Z lengthening of tendoachilles in these patients, what happens? It will lengthen both. It will lengthen gastroc as well as it will lengthen soleus. So what will happen after surgery? Look at this picture and this one. Now the gastroc length is restored. What happened to soleus? Soleus was normal to begin with. Now after surgery, what will happen to soleus? Over-lengthen. Yes, that's the main problem, that soleus, which was normal by tendoachilles, will become over-length. And tendoachilles lengthening leads to unwanted lengthening of soleus muscle. And that is the reason, because soleus is one of the muscle which helps us to remain upright. We are remaining upright because of the soleus is pulling the tibia from behind and keeping the tibia vertical, and that's why we are upright. As soon as that function is lost, the child like this, the tibia will go anteriorly, and once it will go anteriorly, the knee will bend, and So that is the reason tendo-Achilles lengthening should be avoided in diplegics. So what is the surgery which we need to carry out? We need to carry out a surgery which is called a Strier's procedure or a selective lengthening of the gastrocnemius muscle. How we do that we will see in a video later on, but we create a plane between the gastroc and soleus, and then we cut only the gastroc, and this will lengthen the gastrocnemius, will not do anything to the soleus. So now with this procedure, both gastroc and soleus are of normal length. So selective lengthening of gastrocnemius is a preferred option in diplegic. So the take-home message is spastic equinus is a very common deformity. Non-operative treatment which we discussed should be used first, but once the contracture develop, then surgical treatment is required, and in that please avoid tendo-Achilles lengthening in diplegics. For them, the selective lengthening of gastrocnemius is a preferred technique. So that's the most important message. Thank you.
Thank you. Ask that about there is an entity known as a false equinus. Many times a patient coming with equinus, but it is not a true equinus in cases of hamstring contraction.
Okay, so that's come in the decision making, that it looks like the problem is that the knee does not extend fully in the terminal swing, and instead of full knee extension it remains like this.
Paralytic disorders of the foot and ankle, in which mainly spina bifida and polio I am going to cover. But remember that paralytic disorders, so spina bifida obviously is affection, spinal dysraphism, affection of the spinal cord. Poliomyelitis, it is the anterior horn cells of the, again in the spinal cord. But then paralytic disorders can also occur as a sequela of transverse myelitis, that is Guillain-Barré syndrome. So that is at the spinal cord level. At the nerve level, you can have various neuropathies in which Charcot-Marie tooth is there. Then you can have traumatic nerve injuries, common peroneal nerve palsy. And at the muscle level, again, you can have muscular dystrophy. So all these conditions, paralytic disorders encompasses all these conditions. But the principles of management remain the same. You have to see which muscles are paralyzed, what is the effect of that muscle paralysis, what deformity it is creating, and you have to treat them accordingly. So let's start off first with, spina bifida. And in spinal dysraphism, these are the various foot and ankle problems that you can see. Generally, the congenital problems that you can see, they are CTEV and CVT. Congenital problems are CTEV and CVT, and the rest of the problems that I have mentioned, pes valgus, pes calcaneus, equinus, cavus cavovarus, these are all acquired problems. And additionally, in spina bifida, you must be aware that a major problem that you face is neuropathic skin ulceration. This is because these children have insensate skin. Some of the principles I will just highlight before we go ahead with each of the deformities. One is the aim of treatment is a plantigrade braceable foot with preservation of range of motion. The aim is not to achieve a normal foot with normal range of, with normal neurological power. That is not possible. So the counseling has to be accordingly. For the deformities, you have to start off with casting, bracing, and in cases where it is needed, you will have to do soft tissue releases and bony osteotomies wherever necessary. So that's for the deformities. Additionally, these children have muscle imbalances, and therefore to correct that, you would require a muscle rebalancing procedures, that is tendon transfers, as appropriate. Arthrodesis must be, and this is one of the most important points, arthrodesis you must try to avoid strictly in this group of patients because they have insensate skin, and if you combine this insensate skin with stiffness, that's a recipe for pressure sores. And post-op bracing is vital to maintain correction. So see that these are some of the treatment principles. So let's look at each of the deformities. Spinal dysraphism, CTEV. So CTEV is quite common, and the higher your lesion, the higher your meningomyelocele lesion, the higher your incidence of CTEV. So in a thoracic lesion, you would see almost a 90% incidence of CTEV, whereas in a sacral lesion, the incidence drops down. And the thing about these are teratologic deformities, so they are very rigid. These have been present throughout the intrauterine life, and there has been no fetal kinesia because of the muscle paralysis, and therefore these tend to be very rigid deformities, and they are associated with internal tibial torsion. Now, initially, it was assumed that all meningomyelocele CTEVs should go for surgical correction, but papers which have come out in the last decade have shown that Ponseti method is successful in this group of patients. However, there are a few key differences. Number one, you have to be extremely careful while application of cast, while giving the cast padding and while molding of the cast, because otherwise you can land up with skin breakdown. That is very common in this group of patients. Higher number of casts will be needed. The 70-degree external rotation which you acquire with the Ponseti casting in case of non-idiopathic clubfoot, that is not possible in this group of patients. Here you may have to reach maybe 0 or 10-20 degree of external rotation, and if you are not getting any further correction, then you have to go ahead with the tenotomy, and of course the relapse rate is going to be very, very high, as high as 70%. Surgical treatment is needed for resistant cases or relapses. Now, what are the surgeries? Surgeries that you do in these cases again depends on what is the residual deformity. So if it's a complete full-fledged deformity, you would have to do your extensive posteromedial plus posterolateral release, which is done through the Cincinnati incision. And the important thing over here, the difference between this and your release that you do in non-idiopathic conditions is that the tendons are excised rather than lengthened. Remember that in especially the high lumbar and thoracic lesions, these are anyways paralyzed tendons, and if you leave them, you just lengthen them, then they can lead to recurrence. So better is just excise them. If the child is a bit older and the bony deformities have already set in, you have to go for osteotomies. The osteotomies again should, as far as possible, be joint sparing osteotomies. So for lateral column shortening, you can do excision arthrodesis of the calcaneocuboid joint, that is Evans procedure, or excision of anterior process of calcaneum, or shortening osteotomy of the calcaneum. And medial column lengthening you can do with the medial cuneiform open wedge osteotomy. Salvage talectomy has been described in this group of patients. Okay. Then coming to the equinus deformity, again this is seen in thoracic and high lumbar lesions, and again you have to start off with conservative management, casting and bracing. If that fails, you have to go ahead with, in mild cases, with TA excision. In severe cases, you will have to do excision of all tendons plus capsulotomies and release of the calcaneofibular ligament. CVT, the incidence is a bit lesser than CTEV, 10% according to Sharad's study. Initial treatment again is with DOPS with reverse Ponseti, but the chances of failure are very high. Nevertheless, you should apply a few casts because the assumption is that it would make the deformity a bit supple, which would make your surgical release a bit less extensive. Surgery, I think, it has already been covered in the last talk. The principles of surgery again remain the same. It's a complete dorsal and posterior soft tissue release with open reduction pinning of the talonavicular joint. But here again, if your dorsal tendons are paralyzed, you may choose to excise them. And here you should transfer the tibialis anterior to the talar neck because it would provide a tenodizing effect and prevent that talus from again sagging down. Calcaneus is a curious deformity which occurs in meningomyelocele patients, seen in about 10% cases. It occurs in L4, L5 lesions where you have strong ankle dorsiflexors but weak plantar flexors. And the problem with this calcaneus deformity is that it is a predisposing factor for pressure soles of the heel. Very flexible deformities you may try out with AFOs, but most of these cases they require surgical correction. Initial surgical correction may just be with a soft tissue release. An anterolateral soft tissue release would be done. Peabody's transfer, that is tibialis anterior transfer to os calcis, has been described in this condition, but the results are varied in literature. Some authors, they proclaim a good result, whereas others don't. In older children where the calcaneum is already deformed, you would have to do a calcaneum displacement osteotomy. So again, start off with the soft tissue procedures. They fail, go ahead with the bony procedures. Valgus, it is common in ambulatory children. Here, it is very important to differentiate between hindfoot valgus and ankle valgus because both of them can occur in a child with spina bifida. It is important to differentiate between the two because the treatment differs. So in case of an ankle valgus, if the child is young, you would put a medial malleolus screw because that would kind of create a hemiepiphysiodesis, a growth modulation, and will help to correct the deformity. Whereas in adolescents, you will have to do a bony osteotomy, that is the supramalleolar osteotomy. If it is a hindfoot valgus, then you would have to do the posterior calcaneum displacement osteotomy. That is the osteotomy which I described as a part of the triple C osteotomy. So that you would do over here in case the valgus is arising at the level of the subtalar joint. Last we come to the neuropathic ulcers, and that's a real big problem, and that occurs if you have an insensate skin and you have deformities and plus your AFOs are not fitting well. So in this group of patients, you have to be very careful when you prescribe the AFOs. The AFOs have to be very well padded. You have to make sure that there are no pressure areas. Now, if a child comes in with a pressure sore and there is an underlying infection or osteomyelitis, the first stage would be taking care of that infection, which would involve debridement and antibiotics. Once the infection heals, what you would have to essentially do to make that ulcer to heal is you will have to offload that area completely. Because these children are insensate, they would tend to hurt that area repeatedly, which would lead to non-healing ulcers. So the best way to do that is apply a cast and create a window within that cast so that you can do the wound dressing. And then once the wound completely heals, you have to go ahead with the deformity correction so that the ulcer does not recur. So this is an example. This was a child who had a club foot and who was walking on the lateral border of the foot, developed this ulcer. To start with, we applied this cast, we created a window in the cast, and after a few dressings, the wound healed up, and after the wound healed, then we proceeded with deformity correction. So that should be your sequence. If there is an infection, first cure the infection, offload the area by applying the cast, let the ulcer heal, and then go ahead with deformity correction. Finally, I will just take 1 minute over here. So foot and ankle in paralytic disorders. Now polio, we don't see much of polio here, yet I'm going to touch upon this because it is not polio per se, but any paralytic disorder, the principles are the same. Again, you have to see there is a muscle imbalance, there is because of the muscle imbalance, there is a deformity, and along with the deformity in polio, the problem is can also be joint instability. So all these problems have to be solved in order to get a better outcome. So if there is a muscle imbalance, how will you solve that? You would have to do tendon transfers to restore the muscle imbalance. Deformity, again, the same principles for soft tissue releases or joint sparing osteotomies. And if there is a joint instability, you would have to do arthrodesis. So in polio, triple arthrodesis is performed quite commonly for joint instability. Unlike because polio is a pure motor paralysis, unlike in spina bifida where you have sensory problems as well. Now this is an article which I would recommend all of you to read. Hitesh is a co-author in this article, beautifully written article. It is in fact in 2 parts. I am only quoting the second part over here, and there is a section over here on paralytic disorders. And this illustration that is there is a very simple illustration, but it helps you in planning your tendon transfers beautifully. So what this shows the transverse section of the foot. These are the tendons on the dorsum of the foot. These are the tendons on the posterior aspect. Now this line that is there, all the muscles which are there anterior to A line, these are dorsiflexors of the foot. Muscles on the posterior side, these are plantar flexors. And this is the line, this is the axis of the subtalar joint. So all the muscles on the medial side are inverters, all the muscles on the outer side are everters. Now how does this illustration help us to plan our tendon transfer? So here is an example. Tibialis anterior is paralyzed over here, right? So you mark that with a white. What does that indicate? So what deformities would it cause? It would cause a first metatarsal drop, it would cause a medial column cavus, it would cause a forearm pronation. And what are the muscle imbalances? So you can see that a dorsiflexor and an inverter are paralyzed. So plantar flexors are stronger than dorsiflexors and everters are stronger than inverters. Which tendon transfer would solve this problem? So if you transfer your peroneus longus to the dorsum of the foot in line with the subtalar axis, it would correct your first metatarsal drop, your dorsiflexors would get strengthened, and your inverters and everters would get balanced. So a simple illustration, but it can help you to plan your deformity correction. Another example they have given of the CPN palsy, And in CPN palsy, a tibialis posterior transfer would effectively, correct your, help to correct your muscle imbalance. So to conclude, paralytic deformities, disorders, the deformities should be corrected by muscle rebalancing plus deformity correction plus joint stabilization. Not addressing any of the above will lead to recurrence. Postoperative maintenance of correction with bracing is vital. Thank you.
I invite the next speaker.
I think the Sandeep has included many things, so make my job easier. But I'll emphasize few points. It's just last session we discussed a lot on the flat foot, and we are discussing on a cavus foot. The important point on the flat foot, it can happen in the postural as well as ligamentous laxity, or the child would be chubby. We can't see about the medial longitudinal arch. Where the cavus happens most of the time, it's a neuromuscular. So always if you see about a child with unilateral or a bilateral cavus, think about the neuromuscular causes. So in short, if we say the Sandeep's lecture and this one, so it is almost similar to that. It's cavus, it's happened to the secondary to the neuromuscular causes. The basic principles remain the same. So what Sandeep said is almost same. So I'm going to discuss a few points on the cavus. What is a cavus? Etiology, clinical assessment, investigation, and management. As said, the medial longitudinal arch is exaggerated, it's a cavus. So whenever it is going more than the normal, where it is very commonly, it will be associated with the clawing also. If it is because of the Charcot-Maries, or there are the many causes for the cavus, but it's because the metatarsophalangeal joint is in dorsiflexion, it automatically leads to the flexion of the IP and DIP, the PIP and DIP. That is also very common. So it is very common to have a description of both. Whenever we'll see about the cavus, we need to examine about the hind foot, mid foot, forefoot, as well as the great toe and lesser toe deformities. So what are the types of the cavus? As I said, very, very commonly it is in neuromuscular, but sometimes it will be associated. In case of the clubfoot, we describe the cavus, but it's a pronated feet. So it will be also a part of the congenital. It's isolated, or it will be associated with other deformity. But in case of the congenital, it may not progress. If it is neuromuscular, it will progress. So it's like this is the cavus deformity in a congenital talipes equinovarus, which we discussed in morning, its first session. Very commonly, we will see the neurological cases, neuromuscular cases, then due to the muscle imbalance, and because of the muscle imbalance is not getting corrected, it tends to progress, and often it becomes the symptomatic. So what are the reasons there? We'll get the KO-varus or cavus, the Charcot-Marie tooth disease, spina bifida, spinal dysmorphism, as he already mentioned, polio, Paediatric ataxia, and cerebral palsy. Very, very commonly, if you see about the case of the cavus, always check the spine, because many times child may not be the spastic, many times not be polio. Very common have two important cause, spinal dystrophism and Charcot-Marie tooth disease. These are the two important cause for the face cavus. It's whether it is asymmetrical, it is spine, symmetrical, common to have a Charcot-Marie tooth disease. What are the reason in that? What happened in case of the cavus? As we said, medial longitudinal charge is exaggerated, and it may not be associated with hind foot deformity. What are the deformity of the hind foot? At the ankle, it may be having cavus will be associated with equinus, that is equinocavus, and it may be associated with the calcaneus, that is calcaneocavus. It may be associated with subtalar, whether subtalar varus or valgus. Very common in Charcot-Marie tooth, it is common have the pes cavus with the varus, that's called as KO-varus. Or it may be associated with the clawing, may be having in clawing. How does it happen in cavus in neuromuscular cases? As he mentioned that in very rightly, that's because if the ankle dorsiflexion is weak, that can lead to the equinocavus. Because there is no dorsiflexion pull, there is a plantar flexion pull, that can lead to the equinocavus, like that. This is a child's. When there is a plantar flexion weakness, when there is a inability to have tendo-Achilles weakness, it can lead to the calcaneocavus. It's because there is no pull of the plantar flexion, it can lead to calcaneocavus, like that. This is the case in calcaneocavus. When there is a subtalar joint involved, there is a everter weakness, that can lead to the KO-varus, because everter are not functioning. Then this is like this case, secondary to spinal dystrophism. There is an inverter weakness that can lead to the KO valgus like that. It is very commonly seen in the people will get full of because of this flat foot. It's flat foot will hind foot will valgus, but it will be associated with KVS also. And there is an intrinsic paralysis where there is a because of the intrinsic muscle of the foot, it can lead to the clawing of the toes like that. We can see about that. The first ray is drop, and associated with the intrinsic muscle paralysis, there is a greater toe associated with the lesser toe. Complex deformity also common with more than one joint involved, like equino KO varus. How to assess the child with the KVS? Always check whether it is a cosmetic deformity or a symptomatic deformity associated with the pain, callosity, cons or footwear problem. And if it is a neuromuscular, it tends to progress. So always check whether it is in subtalar, ankle, metatarsal, as well as this child has got the unilateral KO varus with the lesser toe problem. That gives idea about the spinal dysraphism. Like I always examine the spine, you say the tough hair present on the back side. So it was very, very common. And as Sandeep mentioned, always examine the sensory problem, because if it is associated with a sensory problem, it can lead to the trophic ulceration, depends on the deformity. If it is a calcaneus deformity, it will have the heel. If it is a plantar flexion problem, it will have at the toe. So because the pressure point is on front, the trophic ulcer happen on front. If pressure point is on back, it will have a calcaneus problem. So we'll see about the clinical assessment, see about component of deformity, determine whether it is supple or rigid, whether it is flexible or correctable or not correctable, whether which compensatory are the compensatory. Which are the compensatory? Very commonly described in a tripod of the foot. The KVS can lead to the secondary pronation of the forefoot, and because of the secondary pronation of forefoot, there is a varus deformity of hind foot happen. This is the example, tibialis anterior weakness in a drop of the first metatarsal, that is called as the pronation of forefoot. And because it is a pronated, forefoot is in pronated, in order to bring the foot into the position, into to touch the ground, the hind foot will go into the varus. So that is lead to the KO varus, and that is the basis for the Coleman block test. We put that into the patient on the first ray is off the ground, and if KVS gets corrected, that means the hind foot varus is flexible or not. That means a Coleman block test. In other sense, if you see about the child with the KO varus of the hind foot, we put off the ground, first ray is off the ground, and then we'll say varus is getting corrected, hind foot varus. If it is there, it's a valgus or not. That will decide whether to do about correction or not. This is a pictorial aspect of the hind foot varus. That's if we put ours off the ground, the first ray is off the ground, then the hind foot is getting corrected or not. This is the Coleman varus, and that cause the varus is rigid. It's not getting corrected. So this is the basic for all the varus correction in KO varus. Always check about the detailed examination of the muscle charting. As Sandeep mentioned, always say about the front dorsiflexion and plantar flexion of the ankle, inverter and everter of the subtalar. So it's always check the manual muscle testing of that. And he rightly pointed out, this is the concept from the Dr. Benjamin Joseph, and he divide into the subtalar into the medial aspect, lateral aspect, and ankle on the front aspect and back aspect. And we'll say whether it is imbalance is present on which aspects, whether you can grade 0 to 5 when there is the empty hole or empty round, it is 0, then it's completely dark, it will be filed. So we can make out whether it is muscle imbalance is there by this. Laboratory investigation, either it will depends on the cause, whether you suspect about the spinal dysraphism, it requires the spine X-ray and MRI. It's required now conduction study and cause to find out the reason, whether it's a reversible or irreversible. Clinical assessment on radiological, we can do about the calcaneum pitch is also described. Mary's angle, which has been actually 0, but it will be more in case of the talus and first metatarsal angle would be there. This is a normal foot, but it will be 0. But calcaneum first metatarsal angle also, in case of the KVS, it is more. So that is the 3 important aspects we can say about the severity. Pedobarography, if it is there, whether the static or a dynamic, whether the KVS is, which part of the forefoot and hindfoot is contact, which is come in contact with the foot, it was required. Coming to the point for the treatment, there is very little role of the conservative treatment because it is tends to progress. But in case of the early deformity, when the child is young, we don't know about the cause, we can do about the molded insole and custom set and monitor the progression of the disorder. But when it's required to do about the surgical treatment, when the child becomes symptomatic and when the orthosis is ineffective and before it will become the stiff, if you don't do the early intervention, the cavus, the flexible varus would be there, but if flexible varus is not getting control, then ultimately it will lead to the stiff, the hind foot can lead to the varus. So the surgical dose would be more if you do intervene late. So that's why decision making, it's important to know about the age, whether it's adolescent or adult or the very young child, underlying disease, location and muscle imbalance. So aim is that to get a pain-free plantigrade subtalar foot, and the method may be soft tissue release, osteotomy and tendon transfer, correct the deformity and restore the muscle imbalance. In short, that is the principal treatment. And mainstay is a tendon transfer. We'll see about the high arch, which you do the plantar fascia release and then do about the muscle transfer, tendon transfer as according to the imbalance. So very commonly it's a cavus is present, which isolated with plantar fascia tight. You do about the plantar fascia release and do about the stainless procedure. If there is a moderate cavus with at the apex with the metatarsal, you do about the metatarsal osteotomy along with the stainless release, do about the metatarsal osteotomy in that. Primary pathology is the tibialis anterior weakness. You do about the basal extension osteotomy along with the tendon transfer. Do the extension osteotomy. The primary pathology is the calcaneus. You do about Similson or the calcaneal osteotomy, which also Sandeep has already mentioned. If it is there, if the varus deformity is fixed, you do about lateral displacement osteotomy of the hind foot. That's been seen there. In a complex deformity in adolescent, it's require about a triple fusion. So it is always essential. The anatomy can be restored by either soft tissue or osteotomy, but it must be maintained by muscle rebalancing procedure. So like as he mentioned about that paralysis there in the case of the triceps surae, if you see that is a front part is working, the lateral half is also working, medial half is also not working. So what you need to do about that, from the two lateral half, one can be transferred. That is, no tendon can replace about the tendo-Achilles weakness, but that is called as the peroneal translocation, or you can do about tendon transfer. This is the picture. This is very important for the understanding. I am not going in detail about each and every procedure, but depends on the site of deformity or the type of deformity. It will require about the soft tissue or the bony procedure plus minus the muscle rebalancing procedure. Summary, we need to find out whether it's a idiopathic or acquired. Acquired is common in the muscular causes. Management, always look for the causes. See about whether rigid or supple. Always correct the muscle imbalance in case of the neuromuscular. Very limited role for the conservative treatment. Always get about the soft tissue plus minus osteotomy plus muscle rebalancing procedure. Thank you.
Quick revision of the theory part. Already we have seen before half an hour, but I'm going to repeat that. We already saw that the procedure for diplegic children is a Strier's procedure, and because it's an easy procedure, you can definitely carry out. First of all, we will understand the concept and then we will see the surgical technique. So the important point is like we need to go between the gastroc and the soleus. So we can go from the posterior side or we can go from medial side. I will show you both the videos so that it becomes easy for you. And then we cut the gastroc part and we separate it from the insertion. That's all. So that's a simple procedure. And let's see the video. The first video is by Thomas Novacek, a very popular or a very prominent cerebral palsy surgeon. So he is going to demonstrate. Which video player should I use? VLC, okay.
This procedure is performed with the patient prone. The musculotendinous junction of the gastrocnemius muscle belly and the tendon is palpated to localize the posterior midline incision. The subcutaneous layer is bluntly dissected to protect the superficial veins and nerves. The sural nerve is identified just beneath the deep fascia in the midline, since it emerges proximally between the two heads of the gastrocnemius. The nerve is mobilized. The interval between the gastrocnemius and the soleus can typically be found fairly easily by passing your finger along the medial side of the gastrocnemius muscle belly proximally. Here is the musculotendinous junction of the gastrocnemius muscle belly and the tendon. Here is the sural nerve. This is the interval between the gastrocnemius and the soleus underneath. At this point, you will need to develop this interval distally to get to the tendinous portion of the gastrocnemius. Use an instrument underneath the gastrocnemius to develop that interval. Once again, note that the soleus fascia is intact. Note that the distal end of the medial head of the gastrocnemius is more distal. The tendon of the gastrocnemius is divided with electrocautery or with the scalpel. With the gastrocnemius completely released, you can see the soleus fascia intact underneath. The knee is placed in an extended position with the ankle dorsiflexed between neutral and 5 degrees of dorsiflexion. Then the gastrocnemius is repaired to the underlying soleus fascia using 2 or 3 interrupted sutures. Typical second rocker position is 10 degrees of ankle dorsiflexion with the knee in full extension. The wound is closed in the typical fashion.
Any question? Was very clearly seen and only the superficial portion was cut. Now the same procedure can be done by a medial approach, keeping the patient in supine position. This was in a prone position. So if you want to combine hamstring and this procedure, prone position is better, but sometimes anesthetists are not very comfortable with prone position. So in that case, we can go for this thing. Now he is approaching from the medial side. This is a medial border of the tibia, around 2 finger width behind that. The advantage, sural nerve is not in the plane of dissection. That's the main advantage. So this is the plane between the two. Now this is the insertion, so we need to go slightly proximally so that we can find the plane easily between two muscles. Finger is the best way to dissect the plane. Any question?
Flat foot and dysfunctional foot. Sir, you have left this topic in your flexible flat foot. Then I will want your comment on this topic, sir.
Okay. Sir, what you, tibialis posterior dysfunction?
Yes, sir.
Yeah, TTPD or something is the name, or adult acquired flat foot, which is very different than this one. To begin with, they are normal. Their arch is normal. After the age of 40, 45, they develop flat foot. And the treatment is very different than what we discussed, because initially the focus should be on tibialis posterior, and when there is a joint deformity, we need to resort to the same procedure, lateral column lengthening or the 3C procedure which Sandeep described.
So you don't see that in the pediatric age group so much. It's more in not even
Not adolescent, that's in adult
It's
or
in
geriatric
the
population.
older patients really.
Geriatric
Once
population.
the tibialis posterior gets stretched out and eventually even ruptures sometimes. So, yeah.
Yeah.
So should we close the session? Okay, we'll felicitate our chairpersons. The faculties which we will be felicitated tomorrow. So may I call Dr. Subhash Chandra sir and Dr. Sandeep Vaidya sir, please do the honors. Thank you, sir. And Dr. Janki, please. So
tomorrow's starting.
Before we break, so we are towards the end of today's sessions. Tomorrow the breakfast is at 8 a.m. and we'll be starting sharp at 8:30 the rest of the sessions. Trauma session is the first, 8:30 a.m. So please be here on time at 8 a.m. and have your breakfast. Next we have the dinner now. It's ready outside and the faculties will be meeting now. Thank you for all the hard listenings and patience listening. Thank you.
Yeah, I think that was